Bueno, listo, bien, gracias por la oportunidad. Tenemos el gusto de abrir este webinar hoy en la tarde. El tema es la reconstrucción de los tumores de acetábulo en tumores óseos. Vamos a tener el placer y el honor de escuchar al doctor Duncan Whitwell, que nos va a acompañar hoy en una charla. Y a todos los asistentes les doy la bienvenida. El doctor Esteban Holguín, que es amigo personal del doctor Whitwell, nos va a ayudar como moderador y va a hacer la presentación y la introducción del doctor. Doctor Holguín, por favor.
Gracias, doctor Chávez. Muchas gracias a todos los amigos que están conectados en este momento, y creo que es un placer presentarles al doctor Duncan Whitwell. Creo que todos lo conocemos, al menos los que estamos en el mundo de la ortopedia oncológica, como un líder a nivel del mundo. Así que muchas gracias, Duncan, por estar acá. Duncan, thank you very much to be here, to give part of your time to share with us. It's really a pleasure to have you here. I think we are really honored with your presence here. And I hope we can enjoy your talk and have a lot of questions to answer today and have fun. Thank you very much to be here.
Amazing technology.
Yes, technology.
We will never have to fly again.
That's not good for me. How can I visit you again?
You don't want these speakers, yeah.
Okay, I'm going to start with the first presentation. I'm going to show some non-tumoral cases to discuss, and after that we are going to direct to your lecture, and after that we can do some questions. Okay, Evelyn, go, vaya, por favor.
Bueno, muy buenas tardes a todos ustedes. Quiero, a nombre de la Academia Escolar, agradecerles por compartir estos espacios de formación médica continua con nosotros. Extender un agradecimiento muy especial al doctor Chávez, que es el jefe del Departamento de Ortopedia del Hospital de los Valles, a la Sociedad Ecuatoriana de Traumatología, al doctor Holguín por moderar y ayudarnos a desarrollar este tipo de espacios. Un agradecimiento también muy especial a la compañía Brown Medical, que sin duda, gracias a la compañía, nos permite apoyarles a todos los profesionales del área de salud, a la gerencia de división de ortopedia y a la gerencia de división de Esculab y particularmente a la gerencia de unidad de negocio de ortopedia. Agradecerles infinitamente, comentarles que desde estos espacios, debido a las circunstancias que estamos atravesando, vamos a seguir en contacto con ustedes y ponernos a las órdenes, como siempre, muchos de ustedes ya nos conocen. La plataforma de formación médica continua que tiene la compañía Brown Médica es la Academia Escolar. Bienvenidos y muchas gracias. Doctor Duncan.
Para todos vamos a empezar con casos no tumorales, dos casos que vamos a presentar de nuestra práctica, y vamos a hacer dentro de esto un sondeo, y espero algunas preguntas que serán resueltas por mi persona y el doctor Duncan. Estamos ahí. Vamos a hablar de reconstrucción acetabular no tumoral. Vamos a presentar dos casos, así que espero que todos nos comenten. En el primer caso, este es del señor Marcelo H., que puedo decir que es pariente mío. 87 años, tiene un BMI de 22 y talla 1,95, es una persona bien grande. Sin antecedentes de importancia su patología. Fue realizado un reemplazo total de cadera hace 20 años en el H6 en Nueva York, y hace 24 meses, es decir, 2 años, tiene un dolor y una incapacidad funcional que ha ido cada vez aumentando y alterando su calidad de vida. En este momento el paciente se encuentra básicamente sentado, cama, silla, cama, una actitud de inflexión de la cadera, en rotación externa, un acortamiento muy marcado, una inestabilidad muy grande y con severo dolor, con un WOMAC de 45 puntos. El paciente tiene esta radiografía. Es un paciente que tiene el reemplazo, un híbrido hace 20 años, ha estado manejado simplemente por clínica del dolor y con una actividad muy limitada. La primera pregunta que yo voy a hacer en este caso, ¿podemos poner, Eduardo, la primera pregunta, por favor?
Sí, por favor, salga la pantalla completa.
Es si es que podemos, basados en esta radiografía, ¿qué clasificación del defecto tendríamos? Tenemos 45 segundos para contestar.
Por
Y
favor,
seguimos.
presionar en la pantalla las opciones para poder contestar los asistentes.
Tres B. Agree, Duncan.
Yeah, it's up and in, isn't it? So it's going in. And that the difference between the 3A and the 3B is that a 3A is up and out and a 3B is up and in. So that's got to be a 3B.
A 3B, I'm agree. What kind of surgical options? ¿Qué opciones quirúrgicas? Porque necesita una revisión. Para este tipo de problemas, una cirugía con distracción o de compresión para la restitución. ¿Listo, Eduardo? Distracción y compresión. Any comment about that, Duncan?
Yeah, so your X-ray, I was a little bit concerned there might be a pelvic disassociation, Esteban, but it was just your picture of the pelvic diagram was indicating a 3B. Yeah, if it's a disassociation, you might need to use distraction, but otherwise you're trying to get a good scratch fit.
Okay.
So because you've got the column, I presume you've got the column intact there. There's no role I can see for distraction.
But it is a good way to restore the normal anatomy and maintain the equilibrium or the balance of the pelvis.
Yeah, so
okay. Here maybe you can have more things to think about the reconstruction.
You've got a very nasty screw there. A very nasty screw there, haven't you? Yeah, sticking out, which is going very close to a blood vessel.
Yeah. Okay, I think that for this kind of patients, we need to prepare really good and have all the instruments we need for the future. Creo que es una cirugía realmente compleja de hacerla, hay que planear y volvemos a las ciencias básicas de que el planeamiento es lo más importante para este tipo de cirugías. Encontramos en el transquirúrgico una metalosis muy severa con un aflojamiento aséptico. Hicimos esterasa leucocitaria, lo que fue negativo, y una alfa-defentina negativa, obviamente con un chequeo prequirúrgico adecuado. ¿Qué es lo que hicimos en este caso? Hicimos un manejo de distracción para este tipo de defectos, pero utilizamos también un proceso de reconstrucción biológica, como es una reconstrucción tipo SLUB, con una malla en el fondo, con reconstrucción cementada y halo injerto en el fondo. Y lo que hicimos es una reconstrucción con una copa con que tiene el free flange, que se llama, que es una copa que ya viene hecha para nosotros realmente poner un inserto adentro y otra copa. Y fue la primera copa que hicimos aquí de este tipo en Quito. Y colocamos una copa de doble movilidad cementada para aumentar la estabilidad, y reconstruimos la pared medial con el halo injerto que ustedes pueden ver ahí. todo puede sonar bonito. Este es del paciente en el postoperatorio. Este es del paciente que no había caminado, tiene muy buena actitud y por suerte salió todo bien a nivel neuromuscular, y eso es lo que queríamos lograr, pero no todo es bonito. A las 4 semanas sufre una caída de su altura y es un paciente grande, hizo un brazo de palanca muy grande y tuvimos esta fractura. Any comment, Duncan? This is a periprosthetic fracture with a complete loosening of the acetabular component after a stairs fall.
I think the only good thing about this X-ray, because there's a lot that's very nasty, is that the failure mechanism has been that the cup has been driven up and out.
¿Me escuchan?
So that you should still have some bone medially and some bone inferiorly. So if you have a look, you've still got a teardrop there, Esteban. So that's good bone. So that's the only good news that you have, is that you've actually got some good bone inferiorly. And I think that's where I try and base any of my reconstructions on.
Sí, lo escuchamos, doctor. Por favor, active su audio.
Ok, ahí estamos. No escuché nada. La siguiente encuesta sería esto. Luego de este trauma y de este horror y de terror que tenemos ahí, ¿qué podríamos hacer para este tipo de paciente? Listo, Eduardo. Okay. What's your opinion, Duncan?
Yeah, I like the idea of maybe the Lumic. That might be useful, but I would probably have used some augments, some trabecular metal augments. I think that I would have put the cup down inferiorly and probably had a superior augment.
Okay, my main idea was to restore the acetabulum again with a stem cup, but it was impossible to convince the family. So I decided to do a Girleston, the famous Girleston. And you know better than me that Girleston was part of your service and is part of the history of Oxford.
That's right. He's a founding professor of my hospital. So he described the excision arthroplasty. I'm happy to say we don't often do that now with modern techniques, but it's still quite useful. Yeah, and it still gets people, yeah, like your patient, up on a frame.
Okay, 4 months up, post-op, I decide to do the Girleston, and 4 months post-op, this is the outcome. Okay, it's not running. As you can see, she's able to walk again, obviously with disbalance with the leg length, but he's right now with no pain. He's able to move again, and I think he's going to recover his confidence and be part of his activity again. I think that the Girleston arthroplasty still is a good available technique, and sometimes those simple things are better. As you can see, the functional result of a Girleston is quite good. It's quite good. Any comment, Duncan?
No, I do think it's got a role still. I tend to use it in the very chronically infected case, where we've got a lot of difficulty in being able to get rid of any infection, and the fact that you haven't got any metalwork there makes treating infection a lot easier. So it's still we still do it, yeah, once or twice a year, despite doing a lot of quite complex acetabular reconstructions, as I'll show in my talk.
Okay, this is piece of cake. Leticia, 72 years. You know the past history of this lady, as I told you. Ella tuvo una fractura de cadera, se le colocó un clavo TFN, falló el clavo TFN y se realizó este reemplazo articular con una copa de doble movilidad y una prótesis Aura, que es con restitución de cálcar en el 2012. 5 años después llega con esta radiografía a la consulta en la cual vemos una destrucción masiva del acetábulo y obviamente del fémur, pero no es de infección. No es de infección. La biopsia, la punción y todos los paraclínicos demostraron que no era infecciosa. This is not infected. This is just maybe a metallosis or something like that. And we have this loosening of the replacement here. Por favor, esta es la encuesta. ¿Qué haría la gran mayoría de los que está con nosotros? Por favor, si es que nos ayudan a contestar. In this kind of cases, do you go for surgery or you do something else to study this kind of patients, Duncan?
Yeah, I would do surgery on him. Do you have trabecular metal augments in South America?
Yeah, we have here in Ecuador, but we don't have all the sizes we need and shapes we need. We just have small wedges, and usually they are not useful for us.
And how expensive are your triflanges? Are they expensive, the custom-made implants?
Around $10,000. I don't know in pounds. 2,000.
Yeah. So,
it's quite expensive.
Yeah.
Okay, I think we are agree with what to do here. Do you know the Integra cup, the stem cup from the French?
Yeah, no, I used the stem cup, and I'll be showing that in my talk as well.
Okay, perfect. Okay, what I did here, I did a historic technique like a slough one. What I did is a jumbo cup for this patient. Is a plasma fit cup from Brown, a multi-hole cup with a lot of cement in the medial wall. And I cemented a constrained insert inside the cup. That kind of technique is described, and obviously I revised the femur as well with this tumoral prosthesis. What do you think to what I did? Is it feasible to do that? Is a good option, or do you think it's going to go to really bad?
I think that there's quite a lot of stress put on the interface of the acetabula with the constrained liner, and so I have had a number of these that I've seen that have pulled out by literally pulled it out of the bone. So I would probably still favor a dual mobility of some description here initially. If the dual mobility fails and we do get instability, then I think I would be then prepared to go back in a few months later when I've got good osteointegration on the cup and then put a constrained in. But I'm very worried about putting a constrained in a fresh implantation, Esteban. I've got to be honest.
Okay, we have been waiting until this happened, but surgery was 2 years ago and still working. Obviously, the lady has a level of activity really low, and I think if she takes care about this, we can do something about. But I'm agree what you said. The level of constraint, I think, is better with a double mobility than a super constrained cup like in this case. Okay, this is the lady 1 year, and is doing okay. Like just a mild limp, as you can see.
That's very good. She doesn't look like she's got low activity. She'll be really walking on that. That's fantastic.
Right now, she's doing low activity because she has breast cancer. Obviously, the weight is not as you see here, and she has problems with the cancer right now. Okay, that's what I wanted to show you. Thank you for your advice and opinion, and please go ahead. No sé si es que hay personas del auditorio que quieran preguntar algo.
Okay, thank you very much. Have I got the screen?
Por favor, los que deseen preguntar usen la herramienta mano alzada para poderles dar uso del micrófono. For sure, microphone.
Okay, I think we have some questions. Seguimos, Eduardo.
Okay.
Okay, go, Duncan.
Okay, have you got my screen? Can you see my talk? Okay, yeah, showing my screen.
Okay, perfect.
Okay, well, thank you very much for the invitation, Esteban. I'm going to just try and talk a little bit about how some of the cases that you've just shown in revision arthroplasty have led me to sort of use a lot of the techniques in my oncology practice, where I also do a lot of pelvic oncology. I do about probably 1 to 2 pelvic resections a month. And I've just found that the same sort of implants, the same sort of largely the same outcomes are being achieved in these quite diverse patient groups. So I have a mixed practice of both oncology and quite complex revision arthroplasty working in a tertiary center. Just to set the scene in revisions, we know that aseptic loosening is by far the commonest reason for why we revise. This is the National Joint Registry in my country, and also the Australian Registry also shows that as well. And we know that we're going to be seeing more and more revisions with the increasing elderly population and the increasing arthroplasty that we've done. So we're not going to be quiet in this area. But my practice in Oxford is seeing a lot of cases referred into me which have been revised before, and you're very much aware that you do get quite a poor result from your revisions. The soft tissues are damaged and the bone quality is often poor. And you can see from this paper that there's a big difference between your outcomes of revisions compared to primaries. This is the problem in the acetabulum. When you get into the acetabulum through scarred tissues, the bone quality is poor. You haven't got that nice cancellous bone that you have in the primary. It's porotic. There's voids. This is a difficult bit of bone to get good fixation on. And also you want to get osteointegration. So you have to load this bone. And that's the secret of being a good revision surgeon, I think. It's understanding the different bone qualities and how you can bring that back to life. This is on the re-revision rate. So this is the chance that you've done a revision in my country and the chance of you having to re-revise it again. And you can see that at 5 years, your chance of needing to re-revise is 10%. And that goes up to 20% at 10 years. So we've got to stop this cycle of revising a hip, then you revise it quite quickly afterwards, and then you have to re-revise it again. Because we know that every revision is a lot harder operation than a primary, with more blood loss, longer operative time, and also patients do have more morbidity after revisions than primaries, and we've got to try and see, can we stop the cycle of re-revision with when we have these cases. And this is a paper that just shows it very nicely from Norway, from the Norwegian arthroplasty register, just showing the poor results you get with re-revisions and re-revisions. And can we break this cycle and try and get our revisions more like our primaries? These are sort of some of the traditional acetabular implants that we've used. They're called cages. There's a number of them on the market. And what we do is largely bypass where the bone quality is poor. We put a bit of bone graft underneath the cage, put some big screws in, and they work very well in the short term, but we are seeing significant failures of these in the mid to long term because we're not really harnessing the biology of the bone to actually osteointegrate into the backs of these cages. And so we get cases like this with big bone graft and cages that after a while they have significant failure, largely due to metal fatigue, or the screws break and the implant loosens in the bone. And we're seeing a lot of these happening between about 5 and 10 years, largely due to the metal fatigue and lack of osteointegration. My practice really has developed quite strongly since the introduction of this material. So this is cortical cancellous bone with all the trabeculae. This is trabecular porous metal. And you can see how nicely it matches the bone. It's got these pores which really do facilitate osteointegration. It's also got these struts. It's very irregular surface, which gives you a very good press and scratch fit for good initial stability. And so my practice in both hips, knees, and oncology has really been brought on a lot by the use of these sorts of porous metals. It's a complex manufacturing process to get this metal made into a porous structure. There's two main types of metals that are used, titanium and tantalum. And they do have a very good scratch fit, that high coefficient of friction. And then if you get good fixation, they're very biocompatible. They're almost isoelastic to bone because of the porous structure. And they do seem to encourage osteoclast adhesion and secondary osteointegration. A lot of the companies that I have in the UK, I think they probably do have a reach into South America and Central America, but they all have a range of these porous materials, a mixture of titanium or tantalum. And they all have good, similar porosities, similar elastic properties, and very similar scratch fit, coefficient of friction properties. So they're very sticky. All good for that poor quality acetabulum that I showed earlier. We like classification systems, and it was great to see the first question from Esteban asking about your classification system. We see it in peripatetic fractures, which is really useful to give you a guide on how you treat these fractures. And we also have it in acetabular and femoral bone loss. You've heard of the name Proposky. His name is key in the classifications for both acetabular and femoral bone loss. And he uses the plain X-ray as the guide to the classification, which then gives you an algorithmic way of being able to reconstruct. And he just talks a lot about trying to use an implant that gets immediate scratch fit to get good initial stability, and then you subsequently get biological fixation, something that normal cages don't. Cages don't get biological fixation, and they're relying on your screw fixation. But we want to get bone growing into the implant to try and see if we can improve the durability of our revisions. So as you heard from the first question, we heard about Proposky's classification. What we want to look at is the 4 parameters of the acetabulum. We want to look at a line drawn above the obturators and the migration of the femoral head. We want to look at the ischiolysis, as this gives an indication of the integrity of the posterior wall. We look at Kohler's line, and this gives an idea of the integrity of the medial wall. And then the final thing is a teardrop, and that often gives an indication of the quality and integrity of the anterior wall. If you look at a lot of your revisions, and that was seen in a number of Esteban's cases, this is often the bone that's not damaged. The bone that's damaged is medial and superior. As the cup migrates up and out or up and in, that's where the damage occurs. So you often do find that this bone is maintained, or the cup's never been sited in this position in the first place, and so this is still pristine. You'll see in a lot of x-rays still good integrity of the bone here. So this lends to the Proposky classification. And I just really want to highlight these. These are the difficult ones, the 3As and 3Bs that Esteban showed. They're the ones that we're not getting good results on. The ones, 2As and 2Bs, largely can just be treated by uncemented cups. And they probably don't need porous metal in some ways, but the 2C, 3As and 3Bs are challenging. And so this is a system of porous metal that I use. It's got a number of different augment sizes and shapes. It's got buttresses as well, and these make up any bone defects. There's a number of different cups. These are the cups that are fully porous, and these give me a lot of flexibility in some of the complex reconstructions we use. But they all have that ability to get good press fit and scratch fit on that poor quality corticated acetabulum, and then they get the osteointegration. This is how the various different augments are used. There's this way you can put them together. If you've got a more medial defect, this is called the footing type technique. If you've just got that superior bone loss, you can just put an augment inside the bone, and that is going to give yourself some superior support for your cup. And the cup is largely positioned between the ischium and pubis inferiorly. Remember, that's where the teardrop is. Remember, that's where the ischiolysis is or is not seen. And that's where you can really base the sitting of the cup down. And the nice thing by doing this is you recreate the hip center, of course. And then if you've got an uncontained defect, you can put these augments or buttresses on the bone, and we call that the flying buttress configuration, which makes up the superior bone loss that you can sometimes see in 3A defects, the up and out defect. So in this case, we've had a look. We think there's good ischiolysis. There's no ischiolysis. There's a teardrop. There's good medial wall because the cup hasn't gone past Kohler's line. But there is a defect superiorly, probably where the cement is. So that probably is close to being a 3A defect. And in this case, you can see I put the cup between the pubis and the ischium, and there's an augment there, keeping the cup in that inferior position to nicely get the hip center in the right position as well, rather than sitting the cup higher, which would miss out on getting fixation in this good quality bone inferiorly. There's a footing type defect as well. In this case, you see that there's mainly a medial defect. We've got dome bone here, and we've got some ischial bone here as well. But here you put the footings together with a bit of cement between them, so you can put footings on top of, you can put augments on top of augments, and you can just put that in a bit like a cork in a wine bottle. There's no screw fixation here. You just wedge it into the defect, and that can give you a nice support of your floor of the acetabulum, on which you can then site a cup normally between the dome and the ischium, still getting rim fixation on your cup. And just to emphasize, I think, the biological nature of the fixation you're getting, this was a case that was referred to me from Germany, where they'd done a very nice reconstruction with a cage after a acetabular fracture. But the patient had mechanical pain. And despite the images and the investigations largely being negative, I explored, and I found that once you took the screws out, the cage just fell out. So there was no osteointegration into this. The only thing holding the cup were the screws. And we went in and gave a porous metal reconstruction with an augment here, down on the ischium and pubis. And this was gaining fixation on the bone. And immediately his mechanical pain had gone. And this has, I hope, a much better chance of being a durable implant akin to a primary with osteointegration into this porous structure. Now, the TMARS system also has some nice little advantages which I've been able to bring into my oncology practice. This is a fully porous cup. You can see that it's going to be absolutely similar to bone in its elasticity. But in this cup, you can't put a liner in, clipped in. You have to cement in a liner. But this also means you can cement in liners such as dual mobility, as well as polyethylene liners if you need to. And you see the cement only penetrates a trabecular structure by about 1 to 2 millimeters. The other nice thing about the fully porous cup is that you can just get a metal cutting drill and you can make new holes wherever you want to put new holes in. So that if you've got a difficult reconstruction, you can actually put holes inferiorly or more medially than you need to really make sure you've got a good fixation of your cup. So no movement's going to occur. So you'll hopefully get some osteointegration. And this cup, because it's got the same modulus elasticity as bone, there's no stress shielding. It loads the underlying bone, which I think is important for getting that bone to restore and bone graft to potentially come back to life. With this cup system, you sometimes have to remove the ring of the cup. And you can do that just off the table with an osteotome. And the reason I do this is that it's sometimes really nice to get some very peripheral screw holes around the edge of the cup so that you can get into the ischium and pubis with some interference screws. And I'm finding I'm doing this probably almost routinely now for my 3A, 3B dissociation cases, because I find getting some inferior screws is really useful to get fixation. And here's, I'm just making that extra screw hole. So here's a case, an augment up there, the revision cup, and I've got some inferior screw holes, really getting good secure fixation both superiorly through the augment and inferiorly. So this system has got other attributes as well. You've got these cages which you can put within the cup. This is not a normal cage. This actually is a cupping cage. So we're still going to get the benefits of this porous structure, but by putting a cage in it, we're just giving a little bit more support. So this is just putting out. This is us just putting the cage in, like the cup in, and there you've got the cage going in to give a further support afterwards as well. And so it acts like a snowshoe to stop any medial migration of the cup. And it gives you extra areas in which you can get screw fixation on, support your cup while it's getting osteointegration into it. I've also done some inferior screws here as well to support it. So the good news is that we're now getting 10-year data of using these porous augments, and really excellent data considering that these are the difficult cases. These are the 10-year data now for 3A and 3B and dissociation type 4 defects. Not bad from Toronto, very good from Vancouver, very good from the charity in Berlin, and not too bad from Finland, where a lot of their re-revisions actually occurred due to instability. And if they maybe had used more dual mobility, we may have seen less revision rate. So very encouraging if you compare to what the success rate is with more traditional ways of reconstructing the acetabulum with grafts and cage. The Chicago group reported 40% failure between 2 and 8 years. There was also the use of oblong cups, which again had a very high failure rate. So I think we're seeing now good 10-year data that this use of porous augments and porous metal is making our revisions more durable, and hopefully getting them much more like our primaries in terms of survival. And this is impaction grafting, which is another good way of treating acetabular defects. But look, in type 1s and 2s, they're fine, impaction grafting, the sleuth technique, but look how the success rate drops away in the bigger defects. But yeah, trabecular metal seems to be able to deal with these defects and give sort of yeah, good 90% survival approximately at 10 years, which I think is encouraging. So I've had a lot of experience of doing those types of cases, and so the last 5 years I've been trying to think about using those types of techniques in our type 2 pelvises in oncology when we're resecting for primary bone tumors. Again, a really challenging aspect of both oncology and also orthopedics in general. Now, when you do tumors, you'll know that sometimes you have to take out the complete acetabulum. Sometimes you can just take out a part of the acetabulum, leaving yourself some bone to work with. And also, we know we sometimes have to do type 1 and 2 resections. You have to take the ileum and the acetabulum, or you have to take the pubis, a type 3, and the acetabulum, all giving different ways of reconstruction. I've just learned over the years that some of the cases seem to be similar. So this was a arthroplasty case with a lot of bone loss around the femur. Previously, you had one of your stem cups. I don't know what make this is, but there was considerable osteolysis of the posterior column. So here you see I've reconstructed the posterior column with a buttress. That's allowed me to put a cup in between the pubis here, a bit of dome bone, and the third point of fixation to get good fixation was with the buttress. And this is the X-ray sort of showing a cup being well fixed with the buttress supporting it posteriorly. This is a case that presented with chondrosarcoma of the posterior column in a 67-year-old lady. I would say a very good spot by a surgeon who was going to do a hip replacement. Just think what a disaster this would have been if a hip replacement had been undertaken. That would have contaminated the acetabulum and probably led the patient to having a hind quarter. Luckily, it was spotted. X-rays and scans were undertaken, and you can see the chondrosarcoma in the posterior column. This is the PET scan that we use for staging of bone sarcomas. We use regularly now in our pelvics a software now which merges both CT and MRI scan, and you can get a very accurate assessment of the tumor, both the soft tissue and the bone. And this is another case, obviously. And we can also get jigs made to make our planning for where we're going to do bone cuts very accurately, and probably more cheaper than other techniques such as computer-aided surgery or navigation. So in this case, we used the CT and MRI scan to plan an operative jig so that we could resect out that posterior column, but making sure we got a margin and we didn't go in anywhere into the tumor itself, because we would like, if we can, just to resect the posterior column and keep the anterior column. And so we did that, and you can see this is the sarcoma within the posterior column of the bone. We've got a nice margin, a good at least 1 centimeter. That's a good safe margin around the chondrosarcoma. But when I came to reconstruct it, the defect I had was quite similar to the revision case, in that I could just reconstruct the posterior column with a buttress. And so, yeah, in the past, we've had to do reconstructions with implants such as this, the saddle prosthesis, which is a horrendous implant, which I consider the devil's tool. It articulates on the ilium and often migrates up. Other techniques we could use, I suppose, are allografts, but they do have challenges. They're difficult to sometimes get the allograft, and the overall graft failure rate is quite high due to infection or non-union. We know that custom implants are also very expensive, and they often do have quite a number of weeks that you've got to order them and to get them made. I work in one of 5 bone tumor centers in my country. This is London. We're here in Oxford. This is Birmingham. There's another place in Oswestry, and that's Newcastle. And so we have to do at least 50 bone tumors a year to be functioning centers. We often do 100 soft tissue sarcomas as well. But if you look at the breakdown of where the main bone tumors occur in the skeleton, you can clearly see that in the pelvis, the commonest ones really are the chondrosarcoma and the Ewings. So they're the major histologies that we deal with. Ewings tends to be the children. Chondrosarcomas is the adults. Chondrosarcomas are only treated really with surgery. So whereas patients who have Ewings would go away for 3 to 4 months and they would have their chemotherapy. In that time, you have the chance to do custom implants. But when you've got a chondrosarcoma that you want to maybe do surgery on within a few weeks, you haven't got the chance to do the custom implant as readily. And also, custom implants are expensive. They're a lot more expensive than off-the-shelf implants. So I've been trying to see whether I could use these off-the-shelf revision implants in our tumor surgery. And so going back to the case that I showed, in terms of the revision case, you get very similar sort of bone defects for your tumor cases. That's the X-ray in the revision case, and that's the X-ray that I used in my oncology case, where I took out that posterior column with after jigging it. And you can see that the X-ray and the reconstructions are very similar. All I would say is probably this remaining bone is probably a bit more osteoporotic often, and the remaining bone in the pelvic in the tumor cases tends to be very good. But we're getting very similar bone fixations with both techniques. The nice thing about the trabecular metal, it just gets that incredible scratch fit. So sometimes you don't even need to use augments. In this case was another chondrosarcoma of the posterior column. But in this case, I could keep a little bit more of the posterior acetabular bone once I resected the tumor. That's the acetabulum there, and this is the cut edge of the posterior wall. But I was able to, with a bit of careful reaming, get essentially a primary hip replacement into him. So you can see there's no need for augmentation here, and I've been able to get a primary hip in this patient, in which he can stand on one leg and function like a primary hip replacement patient, even though he's had a tumor resection.
Go on.
And this is another similar patient, again, largely a primary hip after a tumor resection as well. And I think you can only get this with the extra properties that the porous metal has to get that fixation in the bone. You can also do the same if you've got an anterior column tumor. So this is a chondrosarcoma of the pubis, and you can see it's going into the front of the acetabulum, but the posterior column is intact. So in this case, we planned our osteotomy through the floor of the acetabulum, and this is the patient walking about 3 months after surgery. She's got this primary hip in because we were able to get 3-point fixation, 2 points fixation in the dome bone, and then 1 point fixation down in the ischium. No pubis, but with good screws and good porosity, that's got enough fixation to function for this young lady who's actually a police officer working back after about 6 months, despite a big resection for chondrosarcoma. If you can't get that third point fixation because you've got too much resection of your anterior column, the nice thing is you can put a buttress just on the inner table of the pelvis. So here we've got the ilium here, and this is the inner pelvis. And so we're putting the buttress on the inside of the pelvis with after an ilioinguinal approach. And you can see how that buttress is giving a point fixation for the cup. So we've taken out majority of the anterior bone here, but we've reconstructed it by placing a buttress on. And again, good solid fixation, equivalent to a primary hip, we can gain by placing these augments. This was a very nasty chondrosarcoma that was very large, as well as going into a lot of the anterior bone. We used a jig here. We had that made to plan our osteotomy through the floor of the pubis. A nasty tumor came, and I don't know if you can see here. Again, I put this buttress on, and you're reconstructing the acetabulum here by placing this buttress, allowing the insertion of a primary cup in effect. And again, this patient had the hip centers right, and he had majority of his abductors, so he was Trendelenburg negative afterwards. Sometimes we also use jigs to actually allow us to get custom augments. We don't do this too often, but just occasionally we feel we have to get a custom augment made. We had this jig made, it did a precise cut of the bone, and then we could put a custom augment in its place. And under that augment in the ilium, we could just place a cup on as well. So this is the augment here, and I'm just then using a cup underneath it to make sure I get the cup in the right position. So rather than having a custom, that means that the whole reconstruction is a custom, I'm cutting down the customization just with the augment, and I'm just using a primary cup underneath it. It just, I think, gives me more flexibility to place the cup in the right position afterwards. Sometimes you actually can get the trabecular metal with those inferior screws even if you've taken out a lot of the acetabulum, you've taken out both columns. So here I've taken the ring off and I put those inferior screws to get fixation both inferiorly and superiorly, despite both columns being removed. I kept this patient touch weight bearing for about 3 months, but after 3 months, he's now fully walking on it with osseointegration here and there. So I think that it gives you lots of flexibility to deal with whatever you want. This was an interesting case of a chondrosarcoma which came out of synovial chondromatosis. As you can see, it's largely in the floor of the acetabulum and in the obturator foramen. The dome bone was good. Actually, in this case, I used navigation rather than the jigs. So I used navigation to carve out the acetabulum, keeping free of all the chondrosarcoma in the acetabulum. Took out the hip joint, the ischium, the pubis, and this is what we're left with. We're left with just a ring, a small amount of ileum. Here's the sciatic nerve here, but all the inferior pelvis is gone. This is equivalent to maybe what we've come across in some very bad revision cases. This is a case that I dealt with as a revision with significant osteolysis inferiorly, needing a similar to reconstruction to that oncology case. So in the tumor case, I was able to get fixation front to back with a cup, but I supported the inferior fixation with the cages that you can put inside the revision shell called the cupping cage construct. And you then cement in a liner inside it. And this is similar to what I did in the revision case as well. So this is the tumor case, getting the hip center right, probably less than 30% of host bone contact here. In the revision case, similarly, only about 30% of host bone contact. However, there's enough fixation, enough stability that you can get both of these implants osteointegrating. And we haven't seen any of these failures. This was my oncology case at 3 months, walking for the first time, full weight bearing. He has had a small foot drop, you can tell, but he's walking pretty well. The good news about the oncology case that I had is the remarkable bone fixation, bone restoration that happened. There's no bone graft here at all, but at 4 years, look at how the bone has restored around the cup, really indicating, I think, that this cup, which is isoelastic to bone, is loading the underlying bone very nicely. And that bone restoration is really giving me hope that if this is happening so clearly in our oncology cases, we should be getting that as well in our revision cases as well, trying to get restoration of bone and durability of our implant. Occasionally, I do have to go right up to using these things called ice cream cones or your stem cups based off the old ring prosthesis. There used to be a pedestal cup, which I used to use. Now I use the Lumic, which I think you mentioned before, which allows you to get a good stem in the ileum, and then you can change the version of your cup. So there are some times I use that if I haven't got enough ileal bone to reconstruct using trabecular metal augments. But I don't use it that often. So this is a chondrosarcoma. You put the ice cream cone up the posterior column, but I still try and use the augments to support that ice cream cone. So that actually gets great bone and soft tissue integration around this. So both bone and soft tissue will go into this porous structure, really supporting your cone, your stem cup. And hopefully, again, making this a nice, durable fixation. So this is an RAF. This is a pilot who's gone back to the army after this. He's not flying anymore, but he is in a full-time job in the armed forces in my country with a Trendelenburg negative hip after a big reconstruction like this. And this is also a durable. We haven't seen any failure of this because of the osseointegration that we're getting into those augments. So this is my first series, about 20 cases. We're probably up to about 35 now, which we're just going to write up, just showing a mixture of different etiologies. These are all my adult patients rather than my pediatric. Mixture of partial or complete type 2 resections, a mixture of using trabecular metal, occasional cones, a number of complications of recurrences, infections, but importantly, I've not had one failure of the hardware, not one loosening of an implant, because I think we are getting osteointegration, which is allowing the implant to survive a long time. I do hanging hips. If I'm going back and taking all the ilial bone out, I don't reconstruct off the sacrum. I think that's just too difficult and I can't see any benefit. As Esteban's shown, a good girdlestone can work well, and I would think a patient like this, I try and keep the inferior capsule. I sometimes use fiber wire to really try and lash the femoral head down onto the remaining pelvis. They function like girdlestones at the end of the day. And so I think that's a very reasonable reconstruction when I've not got any ilial bone, because I don't reconstruct on the sacrum. Just finally, the last 2 minutes, it's just to say that we also have to do some quite big reconstructions in metastatic disease as well. This is where we've obviously got the main cancers that spread to bone. You know, there's the cancers like lung and colorectal that don't have a long life expectancy. And then you've got the patients who have breast, prostate, renal, thyroid, who can live years now with metastasis, even in the pelvis. The key thing about acetabulums there is to try and do an extended posterior approach, debulk the tumor as much as possible, get the forces up onto the sacrum and the remaining ilium. There's no real place for biology, I think, in these cases. And I use a lot of transpelvic column-Steinman pins when the columns are damaged. Otherwise, you could just use cages or cement. So you get some quite big defects. This was a myeloma case that was really struggling before the patient had treatment. So we were able to put lots of pins coming in from the ilium with a cage on top to give this patient a reconstruction. And so you can see how we do little incisions at the ilium on the iliac crest, and then you can pass these threaded pins through into the inferior pelvis to give yourself some support, on which I also put a cage. This is called the gap cage, which has got these long flanges which can often get fixation on the remaining ilium, which is also quite nice. And then you can just fix cement. So I tend to use the anterior entry points on the crest to go into the ischium, and then the posterior entry points on the crest to go and pass them down into the pubis. And you get a raft of pins on which you can reconstruct. So here's lots of cement as well. And into this, you can also put a dual mobility bearing if you need to, if you really want to get stability with an enhanced stability bearing. So a difficult case that a lot of surgeons would probably say no to, but I like treating metastatic disease because I think these patients are very, very grateful that you're giving them some care in the last few months of life. This patient had lung cancer, only a few months left of life. She couldn't walk. I felt that it was very reasonable, even though it was a very large tumor, to do this. I debulked a lot of the tumor. We passed the pins down. We put a cage on top, lots of cement, and we were able to get her walking reasonably well with a frame out of hospital for the last few months of life. And I ask all my revision hip surgery colleagues to consider doing these types of operations, because I think it's well within our skill set. And we've had some good results of getting difficult cases needing Harrington pin reconstructions home without any failures before they die. So in summary, I think that my practice has evolved from using lots of this porous metal in revisions to now using it almost all the time in my oncology practice as well. They're off the shelf, they're cheaper than customs, and now we've got clear evidence that both in revisions and in that we've got good 10-year survival, which gives me real hope that we're going to be seeing very similar survival rates in my complex oncology cases as well, whether they're partial or complete. I think the key thing is I'm getting biological fixation. I'm not relying just on screws. I'm getting bone integration into into this implant, which I think is the key thing. And the nice side effect is I also get the hip center right and hopefully optimize the hip by biomechanics. And I rarely now need to go to custom implants. So thank you very much indeed for your time, and I hope we've got some time for some questions.
Thank you very much, Duncan. It was incredible what you showed us. Por favor, si hay alguna pregunta del auditorio, vamos a tener 5 minutos más para poder conversar. Doctor Chávez, ¿alguna consulta? No sé.
Doctor Chávez, por favor.
Ahora lo escuchamos.
Ok. Bueno, primero decía, congratulations, Dr. Whitwell. Excellent presentation. Quisiera saber qué prefiere él como para utilizar halo injerto o las extensiones de metal.
What is your preference right now? Using the metal that you are using or the biological ones with allografts, for example?
I really don't use much allograft at all in the pelvis acetabulum. If I'm doing a type 1 resection, I would bring a free fibula graft in. But my preference now, because of the good results we're getting with trabecular metal, is not to use allograft, because I think that there's a much higher complication rate, infection, non-union, and the trabecular metal is giving me no hardware failures, and getting patients up and around a lot quicker than I think the use of allograft. So I'm almost 100% now reconstructing acetabulums with this porous material.
Gracias. Okay, thank you.
I have a question right here. Do you have any concern about radiotherapy with the metal implants?
That's a really good question. There's no doubt about it that if patients have had radiotherapy before, and then you're going to be putting this in, a lot of the biology of the bone is disrupted. Radiotherapy kills bone, we know that. And when you're doing this, you are relying on osseointegration coming in. But I believe that bone, if it's loaded and given time, can, as you know, come back to life with creeping substitution. So when I am using cases that have had radiotherapy, I really do put lots of fixation in to make sure that that hip has time to recover and come back to life to get osteointegration. So I often put cages and lots of screws and things like, and keep them quite gently weight bearing. Post-operatively, if they have radiotherapy, I'm not too worried, because the evidence, Esteban, is that osteointegration is going to happen within about 6 weeks, or it starts quite quickly. So I think by the time you've done the surgery and you've got them healed, going to the radiotherapist, you've often got that some bone healing into that. So I'm not too worried about them subsequently needing radiotherapy if necessary.
Okay, what is your opinion about the use of denosumab for these cases?
We've used denosumab, yeah, quite a lot now in our GCT cases and also in some of our metastatic cases. I don't use them in our revision arthroplasty cases at all, or in our primary bone tumor cases. So it doesn't. If I have a big giant cell tumor, I would have a very short course of denosumab just to harden everything up, and then go in and do the reconstruction. And metastatic are treated by our oncologists, and that would probably carry on after the reconstruction as well. So yeah, it's got a role in a few of our patients, but not in primary bone tumors.
Okay, we're out of time right now. I want to thank you, Duncan, for your presence here. We really enjoyed your lecture. I'm very happy to see you again. So thanks. Say hi to all part of your team, Max, and thank you for everything, Doctor.
And my best wishes to everyone in South America and Central America, and I hope you're keeping well. We're keeping fine in the UK. Hopefully we'll come out of this in the next few months.
Okay, thank you. We hope.
Thank you very much indeed. Bye-bye.
Okay.